Hello everyone, and welcome to the webinar, Amidst Opioid Crisis, Best Practices for SMVF Resilience, Treatment and Recovery, sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center. My name is Xavier Robinson, and I am a Director of Practice Improvement for the National Council for Behavioral Health. I'm also a proud Iraq War veteran, and I lead our Opioid Epidemic Impact Initiative efforts here at the National Council. Before I begin, I'd like to draw your attention to some important webinar logistics. During today's presentation, your slides will be automatically synchronized with the audio, so you will not need to flip any slides to follow along. You will listen to the audio through your computer speakers, so please ensure that they are on and that the volume is up. You may send us questions at any time during the webinar by typing your question into the Ask a Question box in the lower left portion of your player. Depending on the question, we may type an answer back, or we may choose to save it toward the end. We'll answer as many of your questions as time allows. The webinar is being recorded, and an audio version of the entire webinar, as well as a PDF of the presentation slides, will be available on the Webinar Archives page of the National Council's website within 48 hours of this broadcast. Following the webinar, we invite you to please complete a short survey. Finally, if you need any technical assistance, please click on the question mark button in the upper right corner of your player to see a list of frequently asked questions and contact info for tech support if needed. Now I'll pass things off to Donna Aligata.
Good afternoon, everyone. My name is Donna Aligata, and I serve as the Project Director for SAMHSA Service Members, Veterans, and Military Families Technical Assistance Center. We're delighted to have you join with us today, and I will just start out with a bit of an introduction. I am a person in long-term recovery from alcohol and other drug use, so I'm particularly passionate about this topic. Also come from a military family and am married to a Vietnam veteran in recovery. We work together here, our team. Basically, we serve as a technical assistance center for SAMHSA, Policy Research Associate, and Del Mar New York has managed that for 7 years now. And in our work, we really have worked to strengthen the ongoing collaboration that goes on at a state and territory level on a public-private basis, and that's military and civilian on behalf of this population. This includes doing work in the nature policy academies, implementation academies, a form of strategic planning, and we facilitate collaboration that helps to strengthen the coordination and the behavioral health system in general. So we work with state teams, and it's now 50 states, 4 territories in the District of Columbia that have taken part in our work, our technical assistance work, and it's about implementing best practices and helping service members and veterans to get the services they deserve. And part of that work, we do quite a bit on workforce development and help to build the capacity of the work of our behavioral health workforce and our peers. And so as part of that, you'll see that we're doing this webinar because it's become quite a priority. A lot of us want to understand some of the things that are present in the objectives, which is understanding about the characteristics and risk factors. We know that we have seen and are concerned about the data that shows us that our veterans are in the midst of a crisis, just like we see members of the armed force. They're not immune to substance use problems that affect the rest of society. And at this point, we want to really focus in our efforts to deal with what we see as a bit of a crisis on the opioid epidemic with this population. We know that there are double-edged threats that veterans face, service members and veterans, a lot of issues of untreated chronic pain, lots of risk tied with suicide and other issues. And so today we're going to dive a little bit into those issues and really take a look at some of the new and emerging national best practices, things that all of our different agencies, public and private, are doing to address this crisis, and to really help everyone who participates today to leave with some ideas about what they can take home and do to integrate best practices into their work and to be thinking about this work with addictions and recovery and prevention from a military culture-informed place, from a recovery-oriented informed place. And certainly we're all thinking about prevention. I'm going to also bring to your attention that we have a disclaimer at the front of this that talks about how what we're going over right now it doesn't necessarily express the presentation. It doesn't reflect the views, opinions, and policies of CMHS, the Center for Mental Health, SAMHSA, and HHS. I am going to go forward now with our introductions of our first presenter. It really delights me to have Dr. Kimberly Johnson helping to kick off our webinar, because she really has been a thought leader regarding this topic and has made contributions to the behavioral health field in all major areas: research, treatment, evaluation, prevention. She worked as co-director of the National Coordinating Officer for the Addiction Technology Transfer Centers. And honestly, based on her background, we're very, very excited about having her help today thinking about solutions for dealing with these problems in our states and communities. I'm going to pass the ball now to you, Dr. Johnson, and thank you for serving as the Director of Center for Substance Abuse Treatment.
Thank you. We can go to the next slide. So I'm just going to give primarily a little bit of background and talk about some programs that we have, and I'm really personally very excited to hear what Dr. Drexler has to say. They're doing some really awesome things in the VA. So the Surgeon General's report that just came out recently, Facing Addiction in America, had a little blurb on the military health system and talked primarily about alcohol, but added a phrase about opioid use disorders, which may be initiated when opioids are prescribed following injuries during deployment, are increasing at a high rate and are of concern. So I just wanted to point out that the Surgeon General's report mentioned this issue. Next slide. So a little bit of data. Next slide. I like to always put the opioid use disorder epidemic in context. So this is the number of people age 12 or older with a substance use disorder in the past year, and this is from the 2015 National Survey on Drug Use and Health. By far and away, alcohol, and this is true with pretty much all of our populations, including the military and veterans population, alcohol is the greatest drug of abuse. Misuse of prescription pain relievers and heroin have been growing pretty significantly. So we have about 2.5 million people in the past year meet diagnostic criteria for having a opioid use disorder. Next slide. But what we can see is for non-medical use of pain relievers, so current non-medical use of pain relievers has actually been coming down since about 2010. And the pain reliever use disorder in the past year is relatively stable, except for this is good news with the adolescent population, where it has come down since 2010, 2011. So that's good news. The rest of the population is pretty much stable. It looks like it's probably coming down in the 18 to 25-year-old population as well. Next slide. Probably need another year or so to say there's a trend for that. And then looking at heroin use, and it's hard to see in a slide with this kind of scale, but I wanted the scale to be similar to the scale of the last one. We are talking about, I should say, very low numbers. So a little bit over 500,000 people probably. So low percentages. But what there is, and so because the numbers are low, it's really kind of hard to see from the scale that we are seeing growth in recent heroin use and in heroin use disorder. And it has about doubled over the past 10 years, although it has been, it looks like it's hard to see from the scale. Let's go to the next slide. And the thing that, of course, brings everyone's attention to this is the fact of overdose deaths. We have seen a 4-fold plus growth in the overdose deaths since 2000. And if you look at the second graphic here, what you can see is that just in the past year, 2 years, because it ends at 2015, and we know that it was even higher this past year, that particularly heroin and also synthetics like fentanyl were large contributors to overdose deaths. Next slide. So that's the general population. That's not just veterans. What we know with the veteran population is that illegal drug use is lower than the non-veteran population, but not that much lower. I guess I should point that out. Next slide. So if we look at comparisons, illicit drugs in general, what we see is that veterans overall have lower illicit drug use, lower marijuana use, and lower use of lower non-medical use of pain relievers. But that's primarily because the men who are veterans are less likely to use those drugs. Women, it's about the same as the general population. Next slide. And if we look at it by age, what we can see is that for the younger generation, so 18 to 25-year-olds, there isn't really any difference between the veteran and non-veteran population for illicit drugs in general, and that's primarily because of there isn't any difference in non-medical use of pain relievers. There is, for all age groups, lower use of marijuana. So to some extent, veterans' use, like other people's use, is related to what's available. Next slide. So one of the things I want to point out, because I think it's important, and I suspect the other speakers will talk a little bit about this as well, what's really important is that we recognize and understand the overlap between chronic pain and substance use disorders. When I first confronted this growth of non-medical use of pain relievers and pain reliever addiction back in the early 2000s when I lived and worked in Maine, we really didn't believe that that it was medical use of pain relievers that could lead to having a substance use disorder. And what we know now, we know better now. We know that approximately 32% of people with a chronic pain have a substance use disorder. And the opposite of that is anywhere between 29 and 60% of people with an opioid use disorder have chronic pain. And so these overlap and they're related. And so I just want to point that out. It makes it very difficult because they're related to treat both at the same time, but there are ways to do that. Next slide. The other factor that I think we need to add into the mix is also, I think I have a couple slides on this, depression and trauma, and particularly post-traumatic stress disorder, are risk factors for opioid use disorders, and they are experienced at levels higher than the general population when we're talking about active military people and veterans and their families. Over 50% of VA Veterans Administration patients seen in primary care report chronic pain, and prescription drug misuse among service members and veterans has more than doubled since 2002. So the growth, even though it's lower than the general population, the growth has been similar to the general population. And as you could see on the earlier slide, it's the 18 to 25-year-olds who are at greatest risk. Next slide. So veterans are twice as likely to die from an accidental overdose compared to non-veterans. It's important to assess risk factors for this reason. Frequently, veterans will present to primary care seeking relief from both physical and psychic pain, and it's hard to separate the two. And psychological distress may lead to inappropriate use of opioid medications in patients with mental health disorders and veterans with mental health disorders. Next slide. So here's a little data that shows the overlap. And this isn't opioid misuse, this is just use. So having a prescription for opioids is higher for people that have a mental illness, and then even higher for people that have post-traumatic stress disorder. So you can look at hopefully you can see this on your screen. So it's just having a prescription is higher for people with mental illness and or PTSD. They're also more likely to have a higher dosage. They're going to have a higher duration. and to take multiple medications. So all of these things are potential risk factors, not just for having an opioid use disorder, but also for overusing, for having for dying, even for having a next slide, for having an overdose. The other thing that we have to think about is suicide. Approximately 20 veterans per day die of suicide, and alcohol and drugs are often contributing factors. The highest risk group is people in their middle years. More men, this is like with the general population, more men than women actually succeed in their suicide attempts. Although the women veterans have a higher rate of successful suicide attempts than women in the general population. So this combination of pain, PTSD, or other mental illness and opioid use disorders puts veterans at higher risk for overdose, for suicide, and also other accidental causes of death. Next slide. And I don't want to leave out military families, so I just want to point out some data on, this is wives of military personnel compared to women, compared to all married women, 18 to 49. So what you can see is that they have similar overall rates of drug use, but that the drugs that they use are slightly different. They're less likely to use marijuana, and perhaps, although I don't think this is statistically significant, more likely to use other prescription medications. Next slide. And this is true of children of military personnel as well. Slightly higher, although again, I'm not sure this is statistically significant. I don't have the markers on here, but slightly higher use of illicit drugs than the general population of adolescents, but less marijuana use and slightly higher use of prescription medications. Next slide. So that's the data. I'm going to just talk a little bit about our approach. Next slide. So SAMHSA really takes a public health approach that's multidimensional, and so it's not just treatment. We also focus on prevention and risk reduction, on overdose intervention or prevention, and recovery supports. Next slide. So we serve military personnel and veterans and their families in a number of different ways. And so these are the types of things that we have to offer. We have the block grants, and some states, I had a bunch of state examples and I don't have time. We took them out, but some states like North Carolina use quite a bit of their block grant money to focus on veterans because they have a high percentage of veterans living in their state. All of our discretionary grants can provide services to veterans, and I think I have some data about that in a little bit, because we do serve quite a few veterans in our discretionary grant portfolio. We also have technology transfer and technical assistance, workforce development activities, and health information technology that all have been used to support military personnel and veterans. Next slide. So this is our data from the past 5 years in terms of the total number of, and this is discretionary grants, so this doesn't include the people that are served with the block grant. And this is in the discretionary grant portfolio that we've served about 62,000 people who self-identify as being military or veterans. And you can see the breakdown there. Next slide. A little bit about how the veterans look a little bit different from the rest of the population in the discretionary portfolio. So more of the veterans served are men. I mean that's just, I think, due to the fact that there are more men who are veterans. So it's a much bigger population. That's the the giant red line compared to the short blue line. Next slide. And they skew a little older than most of our grantees, other grantees that aren't veterans. And that's partly because there are no adolescents in the veterans. But even if you take out that adolescent dot, then they still skew older. Next slide. So just a couple programs I'm going to mention. As I said, I had a whole bunch that I could have presented, but there isn't time. So I want to talk about this one program. It's funded by our TCE P2P, which is our Targeted Capacity Expansion peer-to-peer grant program. And this one grantee is a VETS peer-to-peer organization that's in New Jersey. And it actually they do some work on social enterprise programs and helping vets find jobs. And so they are vets who are helping vets through peer mentorship and recovery support, but focused on employment. Next slide. This is just the same program. Next slide. Of course, we have the Technical Assistance Center that has great resources, and this webinar is one of them. Next slide. We have a number of different workforce development and training programs, and I'm only going to highlight just one, the PCSS O and PCSS MAT, which is for physicians, so helping physicians learn more about treating opioid use disorder, or in this case it might be addressing pain. So if you're observant, you'll see that the one that we're highlighting is one that our next speaker did for us in that program. We also have the Addiction Technology Transfer Center that is more for clinicians or programs, and they have offered a number of activities, webinars, trainings on working with veterans. Next slide. That's just another example. Next slide. I want to talk about this one program that was really, really interesting. Up in upstate New York, they had a program that worked with veterans who had frequent rehospitalizations for their substance use disorder, and this is one of our TCE HIT grantees, so Targeted Capacity Expansion Health Information Technology grantees. And what they did was they used a mobile app that was a recovery support app, peer support, and medication, which was primarily, at least initially, Vivitrol. And that combination of activities was introduced to this group of veterans that had a hard time stabilizing their substance use disorder, and they measured the outcome by rehospitalizations, and they found that it was significantly reduced, hugely reduced. Most of the patients had no rehospitalizations where they had repeated hospitalizations in the past, and there were a couple that had some, but this was a group of, I think the first round was 40 patients, and something like 37 of them in the course of this couple-year-long program didn't get hospitalized again, even though they had had repeated hospitalizations before. So great targeted program that was very different from what we usually have to offer. Next slide. So another way that we are helping providers learn about how to better address patients that have specific difficulties is this ECHO. And I encourage everybody to look more into ECHO. We will be using it as a training tool much more going forward. It's basically uses a medical training model that is case-based. And so people bring their cases to a webinar like this and have a conversation. So it's a small group and discuss with an expert what the needs are of their patients and try to do case problem solving. Next slide. So I need to wrap up because I have less than a half a minute left. I just want to say that we are committed to serving our service members, veterans, and their families, and providing the best services that can be made available to them. And I really appreciate the work that we do with our partners, and I will turn it over now. Next slide.
Thank you, Dr. Johnson. Thank you very much. We were excited because we've really been able to, through the TA Center's work with interagency state teams, be able to draw on the strengths that CSAT and CSAT offer as part of the SAMHSA services, and that's helped to really strengthen the awareness for a coordinated response to this public health concern, so thank you. Next, I'd like to introduce Dr. Karen Drexler. Dr. Drexler is the National Mental Health Program Director for Substance Use Disorders at the U.S. Department of Veteran Affairs. Prior to her work here, she worked as a psychiatrist at the Wright U.S. Air Force Medical Center and was on the faculty of the Wright State School of Medicine for a number of years, and especially has had some experience serving as Deputy National Mental Health Program Director for Addictive Disorders and Patient Care Services at the VA in Washington. What's been excited about her work there is the mission of the MHS is to advance quality of care of veterans with mental health and addictive disorders. But she has especially strong research interest in neurobiology of addiction, clinical trials, and health services. And so we're glad to have this resource for our thinking and our work this afternoon. Dr. Drexler?
Thank you so much, Donna, for that very kind introduction, and hello, everyone. I'm so excited to be able to talk with you this afternoon about one of my favorite topics, as Donna said. So next slide, please. So I'm going to take you through a very high-level overview of the VA's response to the opioid crisis, both from our approaches to pain management and trying to prevent opioid use disorders, as well as our response to treatment of opioid use disorders. Next slide. As I'm sure you are aware, the VA's mission, I think, is the best mission on the planet, to care for him who has borne the battle and for his widow and his orphan. We are here for our veterans, both men and women, of course, and for their families to the extent allowed by law. Next slide, please. So the pain challenge, as Dr. Johnson said, the current opioid crisis had its roots in our mistaken belief that we could safely prescribe opioids for chronic, non-cancer, non-end-of-life pain, and that the risk of becoming addicted or of having adverse events was very low. Unfortunately, we've learned over the past 20 years that that's not true, that pain is challenging, but it's not necessarily made better or relieved by opioids over the long term, and the risks of long-term opioid therapy are very high. In veterans in particular, chronic pain is common, and it has a couple of factors. One is, of course, the injuries that are associated with combat, as well as just the chronic pain of aging, that the majority of our veterans are from the Vietnam era and are aging, and like most of us who are in our 50s and 60s and 70s, things start hurting. So there's well over 2 million veterans with more than one pain diagnosis who are being treated within VA, and the sources of the pain are the same as the sources for other Americans, joint pain, back pain being most common. Another unique aspect for veterans, though, is that chronic pain is often severe and complex, and the co-occurrence of post-traumatic stress disorder and opioid use disorder is especially common. Next slide, please. Substance use disorders are also common among veterans treated in VA. Over 500,000 veterans, or 9.7%, were diagnosed with an SUD in 2015, and that compares to about 8.4% of U.S. adults. Next slide. Next slide, please. Thank you. So this, I'm sorry, maybe one too fast. The two graphs were to show the trends in drug and alcohol use disorder diagnoses, and by far the most common substance use disorder in the VA after tobacco is alcohol use disorders. But among the other drug use disorders, for many years cocaine was the most common. It was surpassed by cannabis or marijuana back in 2011. And as you can see, since about 2006 or 2007, there's been a steady increase. That third line, which appears as bright fuchsia on my screen, is the opioid use disorder diagnosis. So it's really the third most common or among the drug use disorder diagnoses. Next slide. So since the early 2000s, we've recognized that this was a growing problem and taken several steps to try to reverse the trend. In 2007, we launched the Buprenorphine in VA initiative, which was aimed to increase the availability of buprenorphine, which is an evidence-based medication-assisted treatment for opioid use disorder. In 2008, our policy requirements changed such that every veteran enrolled needed to have access to medication for opioid use disorder. In 2009, we established the National Office for Pain Management Practices to improve our pain care, and we created standard metrics for pain management therapies. In 2013, we launched simultaneously two important quality improvement initiatives, the Opioid Safety Initiative and the Psychotropic Drug Safety Initiative, to both reduce unsafe prescribing practices and to promote safer alternatives. And in 2014, we began some targeted interventions for reducing opioids and also, importantly, our opioid overdose education and naloxone distribution program that I'll talk a little more about. And just last week, in 2017, we published our updated VA DoD clinical practice guideline for opioid therapy for chronic pain. Next slide. And here's just a few of the important outcomes and the impacts of these quality improvement efforts. So from 2012 to 2016, 170,000 fewer veterans were prescribed opioids for pain. That's a 25% reduction. At the same time that there was a 3% growth overall in the number of veterans receiving prescriptions from VA pharmacies. At the same time, 51,000 fewer, that's a 42% reduction, received opioids and benzodiazepines at the same time. That particular combination is particularly risky in terms of overdose death. And a 32% reduction in the dosage of those receiving chronic opioid therapy, meaning opioid analgesics for more than 3 months. Next slide, please. And this slide has a lot packed into it, but it's just overall will show that we haven't been satisfied with just one or two approaches. It's been comprehensive. We have our guidelines and best practice implementations. We've leveraged our electronic healthcare record to create tools to assist clinicians and healthcare leadership with dashboards that help to prioritize patients that may need additional attention, and also to help leadership know how they're doing in meeting some of these quality improvement goals. We've also been gearing up with alternatives to opioids for pain management, including complementary and integrative therapies, and then educating our providers and our patients through national communities of practice, consultation, webinars, email groups, a particular kind of education that's targeted to the individual, individualized coaching called academic detailing through our pharmacy and benefits management service, a medication take-back program to take unused opioids out of folks' medicine cabinets where they can be misused and dispose of them safely, and then finally informed consent process for patients, both for when they use opioids for pain management and also for treatments for opioid use disorder. Next slide, please. This slide just shows a screenshot of our VA DoD clinical practice guidelines, which are available on the web. They are free and open to the general public. Next slide, please. They're based on a systematic review of the evidence and the well-respected grade methodology of synthesizing that evidence and making guidelines. As you can see, the highest level of evidence is a meta-analysis of randomized controlled clinical trials, and for the substance use disorder guideline, our recommendations really were based on randomized controlled clinical trials or meta-analyses. Next slide, please. This is a comprehensive guideline for all substance use disorders. We highlighted the four most common: alcohol, opioids, cannabis, and stimulants. And there's a lot of detail here. I'd encourage you to check it out on the web. But I wanted to highlight that for opioid use disorders, we have 3 recommended medications and 3 psychosocial interventions. But unlike for alcohol, where we have psychosocial interventions that have been shown to be effective on their own, we really found no evidence that any particular psychosocial intervention was effective without medication for opioid use disorder. Next slide, please. These evidence-based recommendations need to be delivered on a platform of patient-centered care and shared decision-making, where the patient is the expert on his or her life and experience, and the clinicians bring their expertise on the risks and benefits of the full menu of treatment options, and provide this in easily understandable information for the patient to make an informed decision. And we have already developed some wonderful tools, particularly again through academic detailing, to assist patients and providers in making these decisions. There's still more to be done. Next slide, please. So we have been able to increase access to medication-assisted treatment for opioid use disorder. We're still not where we need to be, but since 2010, we've increased the number of patients receiving medication-assisted treatment for opioid use disorder, primarily methadone and buprenorphine, but also on our formulary is extended-release injectable naltrexone. And 34% of patients with opioid use disorder receiving treatment in the VA in FY 2016 received medication-assisted treatment. That's better than where we were 10 years ago. But if you compare the number of patients with other chronic illnesses that have a behavioral component like hypertension or type 2 diabetes, for those illnesses, about 75 or 80% of patients receive medication in addition to the advice for diet and exercise. We're not quite there yet with opioid use disorder. Next slide, please. Next slide. Most of that has been, this increase in access to medication-assisted treatment has been done by increasing access to office-based buprenorphine prescribing. And as Dr. Johnson presented, one of the great resources that we've also taken advantage of in the VHA has been the provider clinical support system for opioid use disorder and medication-assisted treatment. We've increased the number of providers prescribing buprenorphine. On average, it's about 11 patients per prescriber, so these are not prescribers who are dedicating their entire time to office-based buprenorphine. They're simply providing this medication to their patients that they would be treating otherwise who happen to be on their caseload or their panel. Next slide, please. The other initiative that I mentioned is the naloxone distribution and opioid overdose education initiative. This is an important initiative that started back in 2014, and we've distributed over 60,000 naloxone rescue kits to veterans nationwide. Medication-assisted treatment is absolutely key for helping to prevent relapse and also for protecting patients from overdose death if they should relapse. We feel like it's important not only for patients with opioid use disorder, but also for patients who are receiving opioids for chronic pain to receive education about overdose, and also a rescue kit to help prevent accidental overdose death. Next slide, please. Now I'd like to switch gears just a little bit and go from talking about our opioid safety initiatives and our initiatives to increase access to opioid use disorder treatment and step back just a moment for those of you in the audience who are veterans or veterans' family members or providers in the community caring for veterans to give you some general information about VA healthcare and how to access it. So we are the largest integrated healthcare system in the nation. We serve over 8 million veterans at over 1,700 sites of care. And we provide a comprehensive basic medical benefits package to every enrolled veteran, which includes not only primary care and preventive care and hospital services, but also mental health and home health care, all integrated together within a single electronic healthcare system. Next slide, please. For mental health services, you can find more at this website, but it includes both outpatient, inpatient, residential care, and even attending to the social determinants of mental and physical health, including supported work settings. Next slide, please. We've been working to make it easier to find us and to find out how to apply for benefits. So if you just Google or type into your browser www.vets.gov and click on the links, it's very easy to apply online for health benefits, or you can call a number as well, and the information is at that website. Next slide. We've also developed some web-based tools to help educate patients and their family members about mental illness. And one is About Face, which is a wonderful website in which you can learn about post-traumatic stress disorder, about the treatments for post-traumatic stress disorder, and hear from many veterans themselves, their own story and how treatment has benefited them. Next slide, please. We also have partnered with veterans who are themselves in recovery and partnered with our state partners for training programs, and we have peers deployed at every medical center. You can see this slide is actually about a year or two old, so it's not completely up to date, but the distribution is about the same. We have the most of the peers are working in the homeless program or in mental health, but we also have them in SUD specialty care programs, post-traumatic stress disorder treatment programs, and now even in primary care. Next slide, please. We also have a PTSD consultation program, which is available to VA providers, but also to community providers who have questions about treating veterans with PTSD. And you can find that, again, through Googling it, through typing that into your web browser, or calling the number that you see on the screen. Next slide, please. We also have a VA community provider toolkit that has information about military service screening, about military culture, and also more in-depth information about the behavioral health services and resources we have available in VA. Next slide, please. I have a few slides here about another wonderful web-based resource called Make the Connection. Those of us who are veterans can type in a little bit about ourselves, where we served, what branch of service, and receive tailored information just for us. Next slide, please. This shows that there are several video stories by veterans in their own words with a variety of challenges that they've had in life. We have some related to substance use disorders on the website. We're adding new ones all the time, and I'm very excited that one of the projects for this year is to have a couple about medication-assisted treatment for opioid use disorder. So those are stay tuned. Those will be coming. Next slide, please. Also through Make the Connection, we have one of the largest and most engaged Facebook communities in the U.S. government and a robust dialogue with veterans encouraging each other and sharing their experiences. Next slide, please. So in conclusion, I know this has been a whirlwind tour, but I hope you've gotten a flavor of some of the resources that are available and that you will follow up if there are some that you're interested in by following some of those web-based resources. We have learned that pain can be managed safely and more effectively with comprehensive strategies rather than giving just an opioid pain medicine pill. We know that SUD and PTSD are brain diseases that respond well to recommended treatments. And our performance improvement efforts are increasing access to evidence-based treatments and reducing unsafe prescribing practices. And we encourage veterans and their families and those who care for them to access VA services and to partner with us to improve the health of veterans and their family members. Thank you.
Thank you very much, Dr. Dressler. Appreciate your presentation. At this point, I'd like to introduce Dr. Michael Flaherty. Michael has worked with our SMVF TA Center. We're delighted for a couple of years now, actually, and helped to lead the Substance Use Disorder Implementation Academy, which had about 10 teams coming together working to actually integrate the best practices for substance use disorders in their strategic plans. He comes to this work with 27 years of active and duty and reserve duty, so he certainly has some strengths as a captain in the U.S. Naval Reserve, and has been really helpful to us around military culture and how there's an intersection with some of these issues. But especially, he's known nationally for his work with the Institute of Research, Education, and Training in the addictions area, IRETA, and his work with from 2001 to 2011 as he helped to actually launch the Northeast Addictions Technology Transfer Center for SAMHSA and CSAT. We've been delighted to work with him recently because he's been such a wonderful source of information tied with his work with the White House Office of National Drug Control and his work with numerous advisory groups related to the topics that we're talking about here. So I'm pleased to welcome Michael to our call, and I'm smiling because I know he's also a semi-military family member with a daughter who works for the VA and actually works in this field that I hope on this phone right now hearing his wonderful work.
Thank you very much, Donna. That was a wonderful introduction, and my daughter, I'm sure, is listening at Fort Leonard Wood, where she is stationed as a physician now. But next slide, please. And thank you, Dr. Drexler and Dr. Johnson, for excellent information. Of course, we're all going to be addressing the same population today, but I'm going to look at it from the perception of the service member, the veteran, and their families, having been in each of those roles myself. Next slide, please. As a member of the military, today we have a very much blended, diverse population, more diverse and blended than ever in the history of our military. So we have a great need for respect for that, but also to understand their perception that they will seek help either at active duty hospitals or in service at outpatient clinics while on active duty. Veteran centers when they come home, which often are in rural areas not close to a veterans hospital or clinic, and, of course, civilian care. So all three of these entities, and we have all three represented on this webinar this afternoon, are involved in trying to serve the veteran and his or her family. And it's quite a challenge because these systems are often very fragmented and large numbers of people, as Dr. Drexler just overviewed. Next slide, please. Our mission is to serve those who have served by implementing and integrating substance use disorder best practices across systems for the member, the service member, the veteran, and the family. And this, of course, includes prevention, intervention, treatment, and recovery. But the best practices, this is our true 1% population, the honored 1%. Go ahead, please. Next slide. Members of the armed forces are not immune, as we've learned today, to the substance use problems that affect the rest of our society. Although illicit drug use is lower in the military personnel than among civilians, 3.9 versus 17.2% of the population. Heavy alcohol, tobacco use, and most recently prescription drug use are now more prevalent in the military and on the rise. Next slide, please. This is our national data, which Dr. Johnson had in actually two break slides. I aggregated them into one, so you have now in 2015 the sad news of over 53,000 accidental overdose to prescription drugs or heroin, fentanyl, or other opiates. So it's the largest number we've had, and in aggregate that's 1 year more deaths nationally in our population to these drugs than we've lost in all of our combat operations since Vietnam. Next slide, please. Today, 1 in 8 active duty military personnel are current users of illicit drugs. I know that's a question that's going to be asked. Nearly half of active duty service members report binge drinking. It's still the #1 problem in the military. 60% of the 140,000 veterans in federal and state prisons are there because of root cause substance use disorders, and over 50% of male and female VA patients seen in primary care settings report chronic pain. Interesting that the 1 in 8 figure on active duty seems to go up when I looked at the data from Dr. Drexler at the VA system, so that when they report to VA centers for care, it seems like a higher number reporting with pain problems and medication needs than 1 in 8. Next slide, please. In younger veterans, the risk population, age 18 to 25, there's the greatest use for prescription misuse at this time. Today, 11% of service members report misusing prescription drugs, with opiate pain medication being the most frequently misused. Pain reliever prescriptions written by military physicians have quadrupled between 2001 and 2009 to almost 3.8 million, and it's even higher now, and I'll show you that in a second. Next slide. So Dr. Drexler mentioned, and Dr. Johnson, the risk factors that we have with this population that are so unique, and I'll be bringing them into the presentation this afternoon. The first one that I've noticed is the stress of deployments. No military has ever served with so many deployments in their record as the current standing force. Many have as many as 7, 8, or more deployments. In wartime or peace, these deployments are stressful. They cause injury, they cause mental injury, and they're hard on the families. This group of people have a zero-tolerance policy. No use is use, acceptable use. So one time you could be out, and they have to live with that. There's great stigma among their own ranks and among those of us in civilian communities. If they do use, the perception of confidentiality, if they come forward, will they be punished? Will they be discharged? And it's a high area of concern for people seeking help, even when it's iatrogenic or caused by physical or medical illnesses. Pre-existing conditions, chronic pain, post-traumatic stress, TBI is not here, but it certainly should be mentioned, are often masked by the medications which are used to treat them, or in sort of a self-care manner. There's a hotline noted there. And, of course, suicide, which was mentioned earlier by Dr. Johnson. Next slide, please. This is what they come home to, the overprescribing of physicians. So they're leaving active duty, and they have maybe been prescribed medications to topically treat pain. They come back to our communities, and you can see the amount of opiate prevalence in our country today. The dark blue states on the slide you see have sufficient opiate prescriptions for almost every citizen in their state, some even more than one prescription for every person in their state. The yellow is 52 to 71 prescriptions per 100 people in that state. So our country is virtually awash in opiates. Over 320 million prescriptions are active in the United States today for opiates, giving almost a sufficient amount for every American to have access to it should we want it. And, of course, this is the trend which we have to reverse, but this is the trend that our soldiers are coming and sailors are coming back to. Next slide, please. So we have to understand what is our operation plan, what's our op plan here, and understand the world from the perception of the member and his or her family and aligned services. They're frightened, they're scared, they've come into a career in the service, they've become injured or they've become treated, and now they have an illness that they're afraid to come forward with. We must practice our emergency, urgent, and general medicine over a continuum of care with a focus on long-term health, wellness, and recovery, meaning that even if we're providing services, say, on a battlefront, we have to also still think about the fact of how we're going to get this person back into health and recovery and wellness down the road. And that kind of thinking is the change that must occur across systems that we've talked about in the earlier slide of my presentation. Next slide. Understand the belief of service members. I put this here just so you can see their starting point for each member. If it's Army, this is their motto. This we will defend. Semper Fortis, always courageous for Navy. Marine Corps, Semper Fi or Fidelis, we know, always faithful, Air Force above all, and Coast Guard, Semper Paratus, always ready. And this is what they adopt. This is what their mantra is as they go forward, and it drives them to a point where being weak or being mortal is not necessarily something that they're thinking about. Next slide, please. Substance use by military personnel is inconsistent with the Department of Defense's values, warrior ethos, and the standards of performance, discipline, and readiness necessary to accomplish Department of Defense missions. I don't think you can see the citation there, but that's from the Army. That's its actual rule on substance use from a standing order today about substance use. So you can see what they're up against here. Next slide. Military culture. Dr. Drexler mentioned this in her slides, and civilian realities, something to know as the military culture teaches them to emphasize discipline, hierarchy, and readiness. Readiness is the unit goal. Everything is reported on readiness. Anything that happens that reduces readiness is considered high priority and something that will be looked at immediately and addressed. So again, there's not a desire to report oneself as sick or ill. Prioritize the group over an individual. Never leave someone behind. Go back and get them. Many soldiers, after many deployments, come back and go back again just to be with their group again, even if it's different individuals, but to carry the group banner. This is a kind of mental set that we're working with, a dedication, a loyalty, and a defense system. Expect core values, loyalty, duty, respect, selfless service, honor, integrity, and personal courage. Tough it out, in a phrase, is what our soldiers and sailors are doing. Many service members and their families are experiencing these multiple deployments, and the family members go through the same thing. When the member comes home, they have to make an adjustment. Next slide. Next slide. This is, back one, please. This is the combat defense system, soldier, in battle or in a war zone, a sailor or a Coast Guard, airmen, cohesive with buddies. Their mental state is accountable and they're in control. The targeted aggression, tactical awareness, lethally armed, emotionally in control, non-defensive driving, discipline. This is from a study that was done by an Air Force lieutenant colonel. When that soldier or sailor comes home, the mind shifts to the home zone, she called it, where withdrawal from others, lack of control, inappropriate aggression, hypervigilance, locked and loaded at home, ready to go, detached and uncaring, aggressive driving. This is someone who, if the door slams, they jump. If they sleep, they sometimes put the gun under their pillow. And adjustments are very hard because the defense system takes 6 months to 2 years or more to come down. And oftentimes they're back in a redeployment by that time. And treating the pain and their substance use at that time is actually a sense of, for them, subjectively find relief. Next. By seeking treatment, this group of people, though, see that going for treatment is seen as weak. 63% fear leadership will treat them differently, won't trust them, and 59% fear others would have less confidence in them. So it's something that they are disinclined to do. Next slide. This is a Substance Use Affects Military Families, Resilience, Reintegration, Recovery, a pamphlet I passed out in the presentation today. I hope you all got it. It's recently produced. It's a wonderful little pamphlet with a brief screen in it to assess troubles with substance use, and it's open to the family members with many resources. And I just wanted to remind you that it's in part of the presentation today. Substance Use Affects Military Families. Next slide. In sum, so what can we do? Understand this is a valued and unique population, our most valued and unique population, as Dr. Johnson and Dr. Drexler said. Military culture and warrior mind, we have to know that this is not the same as the typical civilian mind coming into our centers, but so much are coming in because of the fact that these individuals do access our civilian systems, or should access our civilian systems just as much as anybody else. Zero tolerance that they're up against: high stress, drinking to cope, denial, co-occurring mental health, substance use issues, family needs and often problems, high rates of PTSD, suicide, homelessness, and a fragmented system. We've already talked about, and we did talk about something with medicated assisted treatment that I'll mention just a little more. Next slide. So what can we do to address this? The first thing we can do is service members struggling with addiction should be discharged and sent to local communities and VA centers where capacity to receive their treatment is only 20% of the existing total population. So we have already an oversaturation of demand and capacity in our systems. And those systems have to grow. So we have to grow our treatment capacity. System where treatment access is greatest barrier to care. In every study today done with veterans in the community, what's the problem of them not getting the care, or those who have overdosed and survived, they could not get into treatment. Nearly 2.7 million veterans have enrolled in the VA healthcare since 2009. That's quite a number, with 54,000 of them expected to need substance use treatment. So you can see that the numbers are high and the demand is getting higher. Next slide, please. Increased population resilience and community prevention and involvement of all services, systems, and communities. Educate, educate, educate. The fundamental approach to solving overdose in America today is seen as a prevention approach, not getting people into it to begin with. And that's building population resilience, recovery capital, and community prevention. Create a systemic approach to identify drug use earlier so as to reduce harm and cost. Introduce brief screening, referral to treatment, and primary care in all the medical centers of the military, active, and veteran, and civilian. I know it's in our civilian communities and growing there with billing codes that are payable. I don't know about it, whether it's adopted yet into our military active service yet. Prescription drug abuse monitoring programs have doctors be able to talk to one another, capable of this person getting multiple doctors, multiple pharmacists shopping. Pain management, medical substance use monitoring, and add to pain management treating the dependence that may occur from the use of the medications to treat the pain management. Next slide. Building prevention, early intervention continue through expand addiction treatment services for the members and their families and community health centers, opening up medicated assisted treatment. Dr. Drexler mentioned the growth of MAT in the veterans population. Active duty members have a challenge with that. They may have to take alternative approaches to their dependence. That is a detox or rehab experience, going drug-free, taking a medical leave of absence, coming back after some treatment, using other kinds of treatment to address pain, etc. If they're going to stay on active duty. If not, they're going to have to go to other levels in our system and get to a point where they can return to where they are safe for themselves in combat. Expand access to care all around, bring our systems together. There are billing codes under ICD-10 unique to veterans and to military. There are over 50 of them. They're the Y and Z codes for those of you that know those things. And in there you'll see a number of codes that can be identified for active duty and military veterans. However, again, the concern is, are we stereotyping or putting the soldier at risk by using those codes? And be sure that when you're using them that you have that consideration in mind. Next slide. Okay, this is probably the most important slide, and I'm saying I'm running out of time. So having Narcan and naltrexone available to high-risk populations, family members, anybody with an opiate diagnosis or who's using them should have a prescription for that with them. And that prescription should be filled. Increased access to MAT we mentioned, and 3 model programs I was going to bring that the CDC reports are showing significant reductions in overdoses, or having access 24/7 to crisis stabilization with MAT treatment, sort of that of an emergency room or a hospital or even a crisis stabilization center. The Boston Medical Center does something like that, and I have access to information from them if people want more on that, but they have opiate urgent care centers where people can go in the city of Boston and initiate 24/7 medical care for opiate dependence. And the Zuckerberg San Francisco General Hospital has changed its whole motif, where every physician in the hospital is trained in substance use, so that every discipline that comes into the hospital screens for every patient on substance use. And if they need specialty care, they call in the addictionologist, where there are 4 of them on staff, to come in and treat the person in any specialty in the hospital. A very innovative model. Next slide, please. He's implementing an operational PDMP. We talked about physician drug monitoring, having a crisis hotline, but more than that, a crisis text line, so that the youth can use it. Youth will not access phones. They will access text, and the sample one is there, a real one, to build peer supports, warm handoffs. Absolutely, AA, NA, the peer support movement in Ohio. There's a Battle Buddy program in Findlay, Ohio, that is just a model one where it's not near a VA hospital, but just to go to the VA center, you're connected with somebody to help in that community. Monitor all overdoses for root cause of that overdose, not to punish, but to educate and find if there is an overdose in a military member at any level, what we could have done differently. Next slide. That's building recovery capital. Using veterans or community family drug courts in the communities, great assets, great vehicles, expert in all medical settings, including craft training for family members so that they can assess and quickly with a validated tool if there is a problem. I mentioned Battle Buddies, sober housing. Next slide, please. Design cross-systems care to build person-centered and person-driven care for continuity of care, integrate care. At all levels, medically and behavioral. Substance use should be a screen in every medical visit and should be continued on in persons in recovery. And when persons are in recovery in the military, they become even a greater asset because now they can help other members in recovery. We need to expand that population enormously. Next slide, please. Identify cross-system barriers. If you see barriers, try to remove them, try to refine them. As we sit down and jointly work at taking away barriers and unifying philosophies for recovery, see if we can, any barriers we note and try to record and see if it has to stay there, or can we make it more simple for the member to go through these systems with a seamless system of care, or ROSC. Next slide. This is what we know we can do. We all know what to do. It's doing it, bringing this fragmented system together for our number 1 population, the true 1% of our country, and I thank you for that.
Thank you very much, Dr. Flaherty, for your presentation, and thank you to all the speakers and presenters. What we have is some questions that have come in, and as I've scanned them here, it seems as though it might be good to just ask you, Dr. Flaherty, to reinforce one more time. You were mentioning some things about the use of AA, NA, 12-step mutual aid support, and how this population can get those kinds of supports in the community. It seems as though there might be some interest in hearing a little more about that. Would you be able to help us?
Sure. It's one of the greatest resources, and you can also start them in your communities, which I've seen happen. But, of course, these are the programs that are fellowships. They are on their own, distinct. You just need to get behind them, ask people to start them. They can be for military or veterans, and some were mentioned in the presentation today. AA, NA, Al-Anon, Alateen are fellowships. They have their own guidelines, but they're free. They're very, very successful in the sense of reaching out and keeping members outside the professional paradigm. Professionals kind of restricted to the time and the day and the hours of service, but this group of people, peers, and the support groups of AA and NA can go 24/7, and that is really priceless at this time, Donna. And anyone needs more information on starting one, I'll be happy to help them.
Thank you so much. Donna, as you mentioned, we've been receiving a number of questions. As a reminder, you can ask a question by typing your question into the Ask a Question box in the lower left portion of your player. And depending on the question, we may type an answer back or save it to the end of the webinar. We'll answer as many of your questions as time allows. So the first question is for Dr. Johnson. The asker asks, can you describe strategies to stop NDs, and I'll add in other prescribers, for over-prescribing? So any strategies to stop prescribers from over-prescribing?
Yeah, well, so the CDC and the VA and DOD have their own guidelines around prescribing, but the CDC has written up some guidelines around prescribing, and I think sharing that with prescribers and helping them understand their alternatives, I think is important. I think we also need to do a better job with pre-service education. So I'm not a physician, so Dr. Drexler may be better able to say how many hours of training she got for pain management or for substance use disorder care, but it's almost nothing. And so people, fall back on prescribing medication. So we have to do a better job helping physicians know what other alternatives are. I also think, and I think younger physicians, new physicians are more open to this than people who are more experienced and have been practicing a particular way for longer, is having decision support tools for physicians to help them make decisions around, is this chronic, is this acute, what are the other options, what are the things that you need to look for in terms of risk factors for substance use disorder when you're treating pain or other or psychiatric issues even. So I think that those are some of the things we can do better. I think, people have talked about reimbursement systems and how what people do is what gets paid. What gets paid for is what people do, and I think that that's the other thing we need to do is work with payers. I mean, the public payers, Medicaid and the VA, but also private payers around what kinds of care they'll pay for. And I think having the kind of evidence that Dr. Drexler mentioned is really important so that people know what is effective and what the level of evidence for those treatments are.
So, hi, Dr. Johnson, if I could just add to what you said, I think it's absolutely true. In my own medical training, I received very little training about how to treat pain effectively, and also very little training about what is a substance use disorder, what are the risk factors, and how can it be effectively treated. So I think there's a lot to be done in terms of better educating physicians and other healthcare providers so that we can make better informed decisions and help our patients to make better informed decisions. I think there are a couple of things in addition to what you mentioned. One that you mentioned in your slide set, which I think is really promising, is the ECHO model. I think that physicians and other healthcare providers are hungry for information about how to provide better pain care, and having the consultation available even and maybe even especially to folks in rural areas through mechanisms like the ECHO model is fantastic. I mentioned briefly, and I could give a lot more information about our academic detailing service in VA, which has been tremendously effective. Essentially, if I could try to summarize it briefly, the idea is that a pharmaceutical company, when they develop a new medication and they have good evidence that it helps from a clinical trial, they don't just stop there with the publication of the clinical trial. They actively try to educate providers about how their product works, answer any questions or barriers they have to using the product. Academic detailing uses many of those same techniques, only instead of in the service of selling a product, it's in the service of closing a gap between what the evidence says is a best practice and what most folks are actually doing. So they target individual providers, they listen to what their concerns are, they listen to what the barriers are, and then they have some amazing resources for education. And the wonderful thing for us in the VA with our electronic healthcare system and our computer system, we have SharePoints that have this information that's available through a couple of mouse clicks. But I think this is something that could be easily adapted by other healthcare systems. And some of those resources are available on the web for anyone. And I tried to point some of those out in my slides, and I know Dr. Flattery did too.
Great, thank you all. We'll move on to the next question, and it's for Dr. Drexler. Please describe the difference between heroin use and heroin use disorder from a criteria perspective.
Sure, thank you. That's a terrific question. So any of the psychoactive substances that are potentially addicting, the majority of people who use them are not addicted to them. But if we expose our brains enough to a high enough dose, long enough, any of us can become addicted. And so I use the term addicted because that's most commonly used. The technical medical definition is now a substance use disorder. And I like that term because it really recognizes that there's a whole spectrum. It's not just an on-off switch, but there are early signs, and then for a mild use disorder that can then progress to moderate or severe. And so our goal is to try, as all of the speakers have said, is to try to prevent the substance use disorder from happening in the first place. Heroin is highly addicting. So many, many people who start using heroin end up addicted to it. And the more potent the heroin, the more potentially addicting, and the more likely someone will end up with a heroin use disorder. But when I say use disorder, there's a set of 11 criteria that are used to make the diagnosis. In order to meet criteria for a mild disorder, you only need 2 of those criteria, but for moderate or severe, it's more like 4 to 6 or 7. And these criteria include things like experiencing urges when you're not using, experiencing an urge or a strong, compelling urge to use, continuing to use despite knowing that the substance use causes medical, psychological, social problems, making attempts to stop on your own and being unable to do so. So I hope this helps, that the difference between use and then a use disorder is when one's ability to control one's use of the substance is impaired.
Great, thank you so much. The next question also goes to you, Dr. Drexler. How is the VA working to encourage help-seeking behaviors?
I'm sorry, could you repeat the last part of the question? How is the VA encouraging what?
Help-seeking behaviors.
Oh, thank you. Help-seeking. Okay. So this is a wonderful question, and as Dr. Flattery mentioned, part of military culture is sometimes not asking for help, for being able to tough it out. And so it is a challenge, especially for veterans, to be able to ask for help. But there are some ideas from military culture that I think are helpful. The idea of having a battle buddy, and that's one area that Donna had mentioned to me when we were preparing for this that's really important, is to emphasize our movement towards engaging more peers. I just briefly glossed over it, but we are very much proponents. It's one of the recommendations from our clinical practice guidelines to encourage mutual help participation. Alcoholics Anonymous, Narcotics Anonymous, other groups like Smart Recovery. So that's one piece. When one veteran can reach out to help another. As I mentioned in the slides, we have some web-based tools that can help veterans with who are curious and maybe reluctant to speak out. They can go to the web, listen to some other veterans in similar circumstances tell their stories, and also talk about what it was like seeking treatment and what they saw as the advantages and disadvantages. What were some of the barriers that they found, and how did they overcome them?
Thanks so much, Dr. Flaherty. Would you like to offer your perspective on veteran help-seeking behaviors?
But mostly it's to use the good guidance of clinical practice. I know that people say, when is it mandatory to report? I think you have to build trust. You have to deal with the fact that whether there is a trauma evident, because oftentimes it's hidden behind that trauma. And when I get into working with veterans or military that have that esprit de corps attitude, I try to relate to it myself with them and understand that they know that I understand what they're going through, and then get their confidence and confidentiality to carefully tell me what they're going through. And then I make judgments as a clinician, very hard ones sometimes, but to help them with their participation. And I noticed that some of the questions were there mandatory reporting requirements. I'm very careful with that. I try not to. I try to find alternative solutions. I try to get family members involved, which often brings down the wall of denial. And using more family members or peers, I build a team around that veteran or that active duty person, and then work from there until I feel that that person is either getting healthy and well or is really a threat to themselves or others and make some hard decisions.
Great. Thank you so much, Dr. Flaherty. The final question that we're able to take today goes to Dr. Johnson, and it's, is mental health counseling encouraged with buprenorphine treatment?
So it depends on what you mean by mental health counseling. There's actually, Dr. Drexler had a great slide that showed, I don't know if we can back up that far quickly enough, about what's effective treatment. And so there are behavioral interventions that could and should go along with medication. I can move these slides, right? I probably can. The one I want. Here we go. So these are Dr. Drexler. This is Dr. Drexler's slide, but these are the kinds of things that have the highest level of evidence. So medication management, along with buprenorphine, so helping people understand their symptoms and manage their symptoms with their medication, contingency management, and then individual drug counseling, which I don't know what's included in that. And Karen, I don't know, you might have something more to say about that. But those are the things there's the highest level of evidence for treating opioid use disorder. So.
Yeah, go ahead. So if I could jump in. So just to answer quickly the question about individual drug counseling, it's a particular manualized version, but it includes things that would be very familiar to those in the audience who do addiction treatment, encouraging participation in mutual help, problem solving, relapse prevention skills, all included. So so the level of what psychosocial intervention is needed really needs to be tailored to the individual. There's good evidence that patients without complex needs who have become addicted to their prescription opioid pain medicine can do very well receiving the medication with very brief counseling from their prescriber or another member of the primary care team, weekly, tapering to twice a month to once a month, which is very brief compared to what I'm used to doing in SUD specialty care. But on the other hand, there are patients with more complex needs who have co-occurring PTSD and traumatic brain injury who need much more in the way of psychosocial services in addition to the medication. Thank you.
Yeah. So it depends on what you meant by what you said to the questioner, and it also, to follow up with what Karen was saying, it depends on what the co-occurring issues are and the level of severity of the patient's needs.
Well, great. This concludes our webinar. I want to thank Donna Aligata as well as Drs. Johnson, Trexler, and Flaherty for offering their insight and expertise today. And thank you for everyone for attending today's webinar. SAMHSA's service members, veterans, and their Family Technical Assistance Center presents Amidst the Opioid Crisis, Best Practices for SMVF Resilience, Treatment, and Recovery. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. You will also receive a follow-up email by the end of the week with a link to view a recording of today's webinar. On behalf of the National Council, Policy Research Associates, and SAMHSA's SMVF TA Center, I'd like to say thank you for joining us today, and please enjoy the rest of your day.